Get going whenever you like, and we'll just keep adding folks as they come on.
Okay, awesome. Okay, so I hope you can hear me great. Okay, so good morning, everyone. So first of all, welcome to our intern group. Hope you are surviving. And as part of, as people who doesn't know me, my name is Dr. Yalanki from Pediatric Gastro. So we are going to start our GI lecture series with liver disorders today. So as you know, liver disorders itself is an extensive topic and it's very hard to cover all of them in 1 hour. So we'll try to focus more on board-oriented topics as well as topics we commonly see in the clinical practice. So let's start with the disorders of bilirubin metabolism. So a little bit about physiology of metabolism of bilirubin. As we know, babies have increased RBCs when compared to us, and they have short lifespan in babies. And with that, breakdown of RBCs produces lots of biliverdin, and biliverdin would be converted to bilirubin, which is attached to albumin. So as a complex, it circulates in our blood, which would be uptaken by your hepatocytes and conjugated and finally excreted into intestines, where it would be passed into your stool as sterco and urobilinogens. And a part of unconjugated bilirubin, and also, so a part of conjugated bilirubin would be converted into unconjugated in the intestines and would be absorbed back into the circulation, which is called enterohepatic circulation. That is intended more for recirculation of bile acids in your body. So what's happening at the level of hepatocyte? So this is the hepatocyte you are looking at, and once the bilirubin is taken up by the actual hepatocyte with help of a carrier protein, the bilirubin would be converted into bilirubin glucuronate in the presence of an enzyme called uridine glucuronyl transferase. So this bilirubin glucuronate is nothing but your conjugated bilirubin, which is ultimately excreted into bile canaliculi. So if you have any problem at the enzyme level or at the level of secretion into the bile canaliculi, you can develop syndromes related to unconjugated or conjugated hyperbilirubinemia. So majority of neonatal jaundice cases are non-pathologic, and most of them are a result of exaggerated physiologic jaundice. It's more because of, as we just talked about, increased production from polycythemia, or like increased breakdown of RBCs in babies, and also decreased clearance because of immature livers in babies. Because most of the times, your liver, UGT, would not reach its full potential until 12 days of age. So until then, there will be a decreased clearance causing increased physiologic jaundice in babies. And also, there is a sterile gut in babies, which allows for increased enterohepatic circulation. So let's move on to breastfeeding jaundice, again, which is a very common cause of jaundice in babies. So people typically call this as breastfeeding failure jaundice because it's more secondary to suboptimal intake of breastfeeding or calorie intake. Because of it, babies develop dehydration. Dehydration further hemoconcentrates the bilirubin, increasing its level. In addition, as you're not getting feeds vigorously, you don't pass. Your gut transit would be slow, so you won't pass your meconium, which again allows for increased hepatic circulation, enterohepatic circulation, as we talked about. Both of them can lead to this breastfeeding jaundice. So treatment for breastfeeding jaundice, again, you need to overcome this by providing the babies with increased frequency of breastfeeds. If there is a problem with latching, we might need to consult a lactation consultant. And sometimes you might need to supplement the babies with formula in order to provide them more calories and more hydration. And most of the time, it occurs after 24 hours of life. Again, any jaundice within the first 24 hours is not physiological, and it's always pathologic. So here, typically breastfeeding jaundice, you see it in the first week of life. And that brings us to the next topic, breast milk jaundice. Again, breast milk jaundice, we don't really know what exactly causing it. There are several proposed mechanisms, but most popularly accepted mechanism is increased content of beta-glucuronidase, which is an enzyme which can deconjugate your conjugated bilirubin into unconjugated bilirubin, allowing for increased enterohepatic circulation. So again, breast milk jaundice typically happens after 1 week, whereas your breastfeeding failure occurs within the first week of life. And the peak typically reaches around 2 to 3 weeks. Sometimes your levels can go up above more than 17 to 25. There are occasional or rare cases reported with kernicterus in breast milk jaundice. So sometimes when you see a level more than 17, those are the babies who need phototherapy to bring the bilirubin down. But most of the times it's a benign condition, and you might want to interrupt the breastfeeding for 24 to 48 hours, which brings the bilirubin down. And in between, you can feed with formula, and if the bili is high, you want to give some phototherapy. And again, prognosis is excellent and does not have any long-term consequences. But in some breastfed babies, it may persist for up to 12 weeks at lower bilirubin levels. So then let's move on to syndromes of bilirubin metabolism. We have total 3 syndromes we are talking about. And the things to remember about these syndromes are, although they can lead to either unconjugated or conjugated hyperbilirubinemia, they would not lead to any liver dysfunction or transaminitis. So that's how we typically recognize them clinically. So first, Gilbert syndrome, which is a very, very common condition. It's an autosomal recessive inherited condition of bilirubin glucuronidation. And it's characterized by chronic recurrent elevations in serum unconjugated levels in response to stress, dehydration, fasting, intercurrent illness, and sometimes menstrual periods in females can cause these intermittent episodes of hyperbilirubinemia. But again, it's like it's so common in white population, and prevalence itself is 5 to 10%. And most of the time, you don't really need any extra investigations, except you might want to get LFTs to make sure there is no transaminitis or liver dysfunction. So if you're seeing a unconjugated hyperbilirubinemia without transaminitis, in a teenager, it's almost always Gilbert syndrome until proven otherwise. And most of the time, you don't really need genetic testing to confirm it, except in occasional cases. Again, treatment is only reassurance, making sure their hydration is well taken care of during periods of stress or infections. And there is like no specific treatment is necessary, and it does not have any long-term sequelae on hepatic function. The next syndrome is Crigler-Najjar syndrome. Again, the problem here is decreased UGT activity. So there are 2 types of Crigler-Najjar syndrome. Type 1 is complete absence of EGT activity, whereas type 2 is markedly reduced EGT activity. Typically, they have only 10% of actual normal activity. So in type 1, the main issue is, again, this is the syndrome where you are not seeing any transaminitis or liver dysfunction. But the main problem you want to avoid is CNS injury. Because these babies are very much prone for actual kernicterus. Again, in a baby with type 1 Crigler-Najjar, because of complete absence of EGT activity, they can build a level of more than 25 within the first 3 days of life, putting them at a very high risk for kernicterus. So these are the babies who need frequent double volume exchange transfusions and continued phototherapy to keep the levels down. And most of the time, as the babies are growing, as they are are more older, they would be able to tolerate bilirubin levels better without developing kernicterus. In type 2, the good thing is you still have some UGT activity, which can be inducible by phenobarbital administration. So if you give phenobarbital to them, their UGT levels can improve, can help with the bilirubin. Presentation is within the first few days of life with profound elevations in the unconjugated billy. Kernicterus is always a concern, and bilirubin deposition in gray matter of the CNS causes high-pitched cry, lethargy, sometimes seizures, and leading to death. Genetic testing is available to check for UGT mutations and to determine whether it is UGT, whether it is Wicklow type 1 or type 2. So early initiation of phototherapy or plasmapheresis is very important. And sometimes you would use bile binding agents such as cholestyramine or calcium phosphate. What they do is they would bind unconjugated bilirubin in the small bowel, and it prevents the intrahepatic circulation, and that's how you would decrease the unconjugated bilirubin levels. And phenobarbital, as we talked about, it would be helpful in Wicklow-Naza type 2. And again, liver synthetic function is preserved. And most of the time, liver transplantation is the cure for these patients. So that brings us to the next syndrome, Rotar syndrome. Again, here the problem is not that UGT activity, it's the problem with secretion once the bilirubin is conjugated. So here you would see both unconjugated and conjugated hyperbilirubinemia. And again, exact abnormality is unknown, but again, it's more of a benign condition, and no specific treatment is necessary. Let's move on to next topic, which is neonatal cholestasis. So a small case scenario here: a PMD calls you when the baby is 10 days old to report jaundice and this otherwise healthy appearing baby. And no labs or studies have been done yet. So as you know, based on our discussion, up to 2 weeks physiological jaundice can occur, and the baby is healthy appearing. So you ask them to monitor the baby for improvement. So PMD calls you back at 3 weeks, at which time the bilirubin levels were done. Total bili was 2.5, and direct bili fraction is 0.8. So at this time, based on these labs, would you need to get additional testing, or would you reassure the mother? And so most of the times, the thing you have to decide there is if the baby has conjugated hyperbilirubinemia or not. So as we know, as your total bilirubin increases, your direct bilirubin automatically and naturally increases. So at what point you would be concerned, right? So if you have a total bilirubin less than 5, you need to have a direct bilirubin value of more than 1 to call it abnormal. But if you have a total bilirubin already more than 5, then you need fractionation so if you have a level more than 20% of total bili, then it becomes abnormal. Suppose if you take a total bili of 10, you need a direct bili of more than 2 to call it as direct hyperbilirubinemia or conjugated hyperbilirubinemia. So what happens in cholestasis? So definition of cholestasis is decrease in the bile flow. It might be related to impaired secretion by hepatocytes or obstruction of bile flow related to your intra or extrahepatic bile duct injury. So most of the times you would only see serum conjugated bilirubin, except in hepatocellular jaundice. And in contrast to the disorders we just talked about, here you would see some hepatobiliary dysfunction with transaminitis. So you would see transaminitis in addition to elevation in your GGT and alk+. And cholestatic jaundice, the prevalence is 1 in every 2,500 infants. So this is a schematic showing general causes of neonatal cholestasis. It can be broadly divided into either extrahepatic disease or intrahepatic disease. Extrahepatic disease is caused by bile duct injury or obstruction, and a prototype of your bile duct obstruction is biliary atresia, which we are going to talk in future slides. And coming to intrahepatic diseases, you can also have intrahepatic bile duct injury, an example of which is Alagille syndrome, where you develop bile duct paucity. You can also have neonatal cholestasis from hepatocyte injury, in which you have like multiple diseases. Majority of your metabolic diseases, including galactosemia, tyrosinemia, hypothyroidism, cystic fibrosis, all of them affect you at the level of hepatocytes, causing neonatal cholestasis. And we have our viral diseases, including CMV, herpes, viral hepatitis. All of them can cause cholestasis. And there is other variant called idiopathic neonatal hepatitis, where the cause is not known, but we can talk about it in future slides. So first, starting with obstructive cholestasis, we are going to discuss about biliary atresia. Again, biliary atresia is the most common indication for liver transplantation in pediatric age group. And we don't really know where exactly it's coming from, and cause is unknown. There are like a lot of presumed hypotheses, but typically people say you start developing inflammation from the time of birth, slowly causing chronic inflammation and fibrosis in your bile ducts, ultimately causing obliteration or discontinuity of your extrahepatic biliary system, resulting in obstruction to bile flow. And typically, as long as you can diagnose biliary atresia early, with early Kasai procedure, the prognosis is good. Clinical manifestations, as you know, most commonly you see jaundice. The other most important thing you will be looking for is ecolic stools. Although ecolic stools will be seen in many other conditions, the ecolic stool with biliary atresia, you will be able to recognize it. It's very pale. And as you are not passing your conjugated bilirubin into intestines, all the conjugated bilirubin kind of like regurgitates into your blood, which will be excreted by your kidneys and then the urine, which gives a dark urine color to your urine. And growth failure is a common association with biliary atresia. And you typically see hepatomegaly. Splenomegaly is like a late finding. So again, labs which show conjugated hyperbilirubinemia with a level more than 2 milligrams per deciliter or more than 20% of total bili level. And there is a mild to moderate increase in your AST and ALT, but you would see a disproportionate and significant increase in your GGT, in addition to alkaline phosphatase, indicating biliary obstruction. And initially, your albumin and PT are normal, indicating normal synthetic function, but with progressive disease, they can decline. Again, so what would you expect on radiology, on imaging with biliary atresia? So here, you're looking at a gallbladder in a normal individual. Here you could see it's long and it's the walls are pretty smooth and regular. Whereas this is a biliary atresia baby, at 8 weeks, you could see a shrunken and irregular gallbladder. So which is a common finding with biliary atresia. And sometimes you would see absent gallbladder or atretic gallbladder in biliary atresia cases. So the other finding you would be looking for on ultrasound is triangular cord sign. So again, so looking this at a surgical specimen. So this is the surgical specimen removed at the time of Kasai procedure. So this is the common bile duct. This is the cystic duct. And this is nothing but your gallbladder. You could see how irregular and atretic this is. And here, this is the bifurcation of your ducts, your hepatic ducts. And this is where you would see the obliteration. You would see the chronic inflammation, scarring, and fibrosis. So this is called a fibrous remnant of porta hepatis, which is triangular in shape. So when you look at it on the ultrasound prior to Kasai, you will be able to appreciate this triangular cord sign. So when you have a baby with clinical presentation as well as labs and ultrasound, more consistent with biliary atresia, next step you might want to consider is HIDA scan. Again, the one you are looking at here is the normal HIDA scan. So typically when you are getting high-res scan, the babies will be given a tracer, which is technetium, given into their blood, which will be taken by your hepatocytes, lighting up your liver first, then lighting up your hepatobiliary system. So this is the image taken at 5 minutes. It's called early phase image, where you can see a significantly lighted up liver, right? Then you can, at 5 minutes itself, you can already see the excretion of actual tracer into the CVD. And this is the late phase where the image was gotten at 45 minutes. You could already see lighted up gallbladder. And most importantly, you are already seeing the tracer in duodenum, which indicate a good patent hepatobiliary system. Here, this is the high-res scan in a baby with biliary atresia, where you could see the liver has uptaken the actual contrast, so it lighted up. But I can't see it. So this is the image taken at 120 minutes. I don't see the gallbladder here. I don't see any common bile duct, and I don't see any activity in the intestine. So this point here where you're seeing is bladder, it's used for control, but I'm not seeing any trace of activity in the intestine. So typically before doing the high-res scan, some people recommend giving phenobarb for 3 to 5 days. But again, if you have a baby presenting at 2 months, the treatment is already delayed. If you are delaying the high-res scan for like 1 more week, it's not really preferable. And the problem with high-res scan is it's a pretty sensitive test. So if you have a normal high-res scan, which rules out biliary atresia, but if you have a positive high-res scan or if you have an abnormal high-res scan, it's not specific for biliary atresia, and it won't stop you from doing the actual liver biopsy. So you still need liver biopsy when you have a abnormal high-res scan. So it brings us to liver biopsy next. With liver biopsy, the characteristic findings you want to see with biliary atresia are plugging of your bile ducts. So you can see bile duct plugs in the liver. In addition, you would see a lot of chronic inflammation and fibrosis in the parenchyma, in addition to bile duct proliferation, inflammation, and edema. And again, as we talked about biliary atresia, it's a progressive process. With that, if you do the high-res scan or liver biopsy too early in the process, at which time you might not be able to see full findings of biliary atresia. So if you have a patient where you have gotten the liver biopsy too early, if you're like still suspicious of biliary atresia later, you might need to repeat. So again, your gold standard for the diagnosis for biliary atresia is intraoperative angiogram. So typically it's done on the operating table when you are going for Kasai's procedure. So where a surgeon is trying to inject actual contrast into the bile ducts, and they would be able to track it proximally into the liver. You can see the ducts here, you can see the gallbladder, and they can also track it into the intestine. That's how they would try to see the patency of biliary system. So if it is like not patent, then ultimately it's biliary atresia, and I might have to proceed towards actual Kasai procedure. So as a Kasai is a life-saving procedure for biliary atresia babies. And again, it was invented in 1968. Prior to Kasai's procedure, there was a very low survival rate in biliary atresia babies. The survival rate was known to be less than 10% at 3 years age. After invention of this Kasai procedure, the survival rate improved to 50% now in a 3 to 4 year old. So again, with the Kasai procedure, what you are trying to do is you are removing the abnormal parts here. You are removing your gallbladder, your CVD, and your atretic hepatic ducts and the portal plate. And you are connecting the proximal small bowel, which is nothing but the jejunum, to your liver directly. And that's how you are decompressing the liver and you are restoring the bile flow into the small bowel. And there are a few studies done looking at early treatment with Kasai, how it improved the actual outcomes and overall survival. So a study done by O et al. Showed like a significant difference in their outcomes when it was done before 9 weeks and after 9 weeks. So there is, like, you can see the difference. When it's done before 9 weeks, there is a 83% survival rate when in contrast to 35% survival rate after like 9 to 10 weeks age. Patients older than 90 days can still have 13% chance of survival with native liver. So you might still want to consider Kasai procedure in them. And again, liver transplantation, as we talked about, this is the most common indication for pediatric liver transplantation. In adults, most common liver transplantation indication is hepatitis C virus. So in a biliary atresia case, the indications are primary failure of Kasai, or if you have persistent cholestasis even after you did actual Kasai procedure, or if you have refractory growth failure, or if you have worsening liver disease even after Kasai. Let's move on to the next topic. Again, we talked about intrahepatic causes. One of the causes is Alagille syndrome, to deal with the obstruction of intrahepatic bile duct obstruction. So it's a dominantly inherited disorder with variable expressivity. And the gene identified is JAD1. And again, as we are talking about variable expressivity, you have like multiple manifestations of the syndrome. You don't need to have all those manifestations to diagnose Alagille syndrome. So from liver standpoint, you need a neonatal cholestasis with pale stools. And dysmorphic facies is very common with Alagille syndrome. You typically see a triangular face in these babies with a broad forehead and a pointed chin. In addition, you typically see a straight nose with a bulbous tip, so if you see a Alagille baby, you would never forget. So, and congenital heart disease is very common in these babies, and the most frequent lesion is peripheral pulmonic artery stenosis. But you don't need to have pulmonic artery stenosis. You can have pulmonary atresia, either ASD, sorry, excuse me, VSD or tetralogy of Fallot as part of the presentation. Vertebral anomalies are also common, and you typically see butterfly vertebrae, and sometimes you see hemivertebrae. And there is a characteristic eye finding called posterior embryotaxon, which we are going to see on the next slide. Here, so this is the junction between your cornea and iris. That's called Schwab's angle. In patients with Alagille syndrome, you'd be able to see increased prominence of that Schwab's angle, which is called posterior embryotaxon, and typically identified by our ophthalmologist. And here, this is the X-ray spine done in AP view, and you would be able to see these butterfly vertebrae in the thoracic and lumbar areas. And this baby had a heart surgery for Alagille syndrome with congenital heart disease, so you are seeing these wires. So what are the other causes of obstructive cholestasis? So you can have choledochal cyst, which can be diagnosed with ultrasound, which can also present with neonatal cholestasis. You can have cystic fibrosis, which again, we know cystic fibrosis causes dehydration of all body secretions, especially in your ducts. And that happens in your hepatobiliary system as well, with thick inspissated secretions blocking the ducts, causing cholestasis. And neonatal sclerosing cholangitis is an autoimmune condition which can cause inflammation and bile duct injury and obstruction. So then coming to hepatocellular cholestasis, as we talked about this variety, it's called idiopathic neonatal giant cell hepatitis. And the characteristic findings on liver biopsy in these patients is widespread giant cell transformation. And most of the time, we don't really know the cause of this condition, but it's presumed to be associated with infectious or metabolic or syndromic disorders. And they need a close follow-up and supportive therapy and may self-resolve on its own. And the other cause of hepatocellular cholestasis, as we talked about before, is infection. Any sepsis or UTIs or any viral infections, including CMV, HIV, touch infections can cause hepatocellular cholestasis. And we have like many genetic and metabolic disorders which can cause cholestasis in babies. Alpha-1 antitrypsin is one of them. You have your tyrosinemia, galactosemia, hypothyroidism, and panhypopituitarism causing cholestasis. And TPN-induced cholestasis, again, very common in our NICU babies. So when you have a baby with neonatal cholestasis, what are the questions you want to ask? So ultimately, you want to know if there is any recent history of infection. So you will be ruling out UTIs, sepsis, viral infections. PD history and history of weight gain is also important because in metabolic conditions, we know you will be dealing with either failure to thrive or like anorexia or jaundice. With jaundice, and bowel history is important because vomiting can be commonly associated with metabolic disorders. And delayed stooling can be seen with CF. You want to get the history of diarrhea as it can be associated with your metabolic diseases. History of clay-colored stool is very important. And history of dark urine color is also important. And source of nutrition, you might want to see what the baby is feeding on if you are considering conditions like galactosemia. So you might want to evaluate for any lethargy because sepsis or infections can cause that. And panhypopituitarism, again, it can be a part of septo-optic dysplasia. And boards love that topic. So whereas with septo-optic dysplasia, you can see optic nerve hypoplasia, you will see absence of corpus callosum, and in addition, you will see panhypopituitarism, which can cause neonatal cholestasis. And you might want to know any history of excessive bleeding, and family history is very important for your Alagille syndrome, alpha-1 antitrypsin deficiency, and also PFIC, which is progressive familial intrahepatic cholestasis. Consanguinity would help you to look at autosomal recessive pattern. And also, it's always important to get history of maternal infections during pregnancy to assess for touch infections. So physical exam, you need to have a global assessment of these babies, especially when you are considering syndromes, right? So you might be looking at their face for any dysmorphic features. As we talked about Alagille, in the hint, you will be able to find actual posterior embryotoxin, and you need to look for hard findings in the palm of murmur, especially for Alagille syndrome, or if you are considering syndromic biliary atresia, where you can have a situs inversus. And it's always important to assess liver size, spleen size. Skin, you'll be looking for jaundice and also rashes, petechiae, and always important to look at the diaper to look for pale colored stools and also to look for dark urine. So, and again, coming to labs for neonatal cholestasis, these are all labs for the conditions we just talked about. You always want to get a direct fraction to look for conjugated hyperbiliary. You want to look at your GGT to assess for biliary obstruction. You need to assess the liver synthetic function by getting PT-INR in addition to albumin. And when you are already going into acute liver dysfunction, you can also develop hypoglycemia. So you need to look at glucose, get urine and blood cultures to rule out sepsis, and viral serologies to look for touch infections and CMV. And always follow newborn screen. It's very important because newborns can rule out multiple metabolic conditions, especially your galactosemia, tyrosinemia, CF, and hypothyroidism. So the imaging studies and neonatal cholestasis, you want to get ultrasound. We already talked about biliary atresia findings. You can also be able to evaluate choledochal cyst. HIDA scan, we already talked about that. Management of cholestasis, it mainly depends upon treating the actual underlying condition, but there are some general principles. The most important thing is, your hepatobiliary tree is not patent, so there is no communication between your liver and your small intestine. So with that, the bile is not getting transmitted to your small bowel, so which causes fat malabsorption, because your fat absorption needs bile forming cells. So with fat malabsorption, you would develop failure to thrive or growth retardation. In addition, you are at significant risk for fat-soluble vitamin deficiencies. So with that, these kids need optimization of their nutrition and growth, and you want to put them on a high MCT formula instead of actual LCT formula. LCTs are long-chain triglycerides, which need bile for the absorption. Whereas your medium chain triglycerides, the MCTs, they don't need actual bile for the absorption. So you want to consider putting them on a high MCT formula like progesterone to improve the actual fat absorption. And you might need to supplement them with fat-soluble vitamins. And all these cases consider sodiol to help bile flow. And so we should continue monitoring them with routine physical exams and lab testing to monitor for any signs of progressing liver disease. So again, this is one of the topics which are more likely to appear on boards. That's the reason why I'm talking a little bit more about alpha-1 antitrypsin. The alpha-1 antitrypsin deficiency is an autosomal recessive disorder. It's caused by mutation in SERPINA1 gene. And as you know, it's a protease inhibitor which is required by lungs to prevent destruction of alveolar tissue, but it's produced in the liver. So typically in the liver, damage is not related to absence of alpha-1 antitrypsin, but it's more related to deposition of this abnormal protein. The problem here is protein folding. So when that's affected, your endoplasmic reticulum is getting deposited with a lot of alpha-1 antitrypsin, and these alpha-1 antitrypsin deposits cause liver injury. So typically normal allele for alpha-1 antitrypsin is PIMM, but if you see G allele, it's abnormal. So PIZZ is a homozygous alpha-1 antitrypsin condition where you see significantly low alpha-1 antitrypsin levels. And a small percentage of these homozygous babies, they can develop neonatal cholestasis. And some of the kids, they develop childhood cirrhosis. And typically, for treatment for alpha-1 antitrypsin is supportive, but the patients already presented with cirrhosis and portal hypertension, then they might need liver transplantation. And coming to Wilson's disease, again, this is a board's law, this topic. So Wilson's disease is a result of mutation on chromosome 13, and the affected gene is ATPB7. And ATPB7 is a copper transporting ATPase protein. And when it's affected, you will not be able to incorporate actual copper onto cellular plasma. And the other problem here is problem with biliary excretion of copper. So, and again, this protein is needed for biliary excretion into your stool. But when it does not happen, all this copper can get deposited in your liver. And once your liver cells are saturated with copper, this copper is going to spill into your circulation, then gets deposited into other parts of your body, causing extrahepatic manifestations of Wilson disease. And typical hepatic manifestations of Wilson's disease, they can range from asymptomatic hepatomegaly to more subacute or chronic hepatitis. Occasionally, kids can present with acute hepatic failure. And sometimes kids might present with cirrhosis by the time they present to AGI, and they will be seen with portal hypertension and variceal bleeding. And neurological manifestations, typically they say your liver manifestations precedes 10 years precedence of liver manifestations before your neurological manifestations. And neurological manifestations are mainly because of copper deposition into your basal ganglia, which plans on motor coordination. So you develop lack of motor coordination, coriform movements, dystonias, dysarthrias, and deterioration in school performance. And boards love to ask about a teenager who presents with decreased school performance, all of a sudden personality changes, behavioral changes, psychosis or depression, and they would give you mild elevation of liver enzymes. That's when you need to suspect Wilson's disease as the probable cause. So psych manifestations we just talked about, and again, sometimes Wilson's disease patients, they can also present with Coombs negative hemolytic anemia. Again, increased copper in your circulation can be toxic to your RBCs, which can cause hemolytic anemia. So the diagnosis, typically, you'll be looking at multiple things. There's like no single diagnostic test to diagnose actual Wilson's. So you'd be looking at decreased, you need to suspect in any teenager or children after 5 years of age who presents with unexplained acute or chronic liver disease or neuro symptoms or behavioral problems. And so as you don't have incorporation of copper into celluloplasmin's half-life decreases. That leads to decreased serum celluloplasmin levels. Typically, they are like less than 20 in Wilson's disease. And demonstration of KF rings, you would be able to detect that on slit lamp exam, and which can be detected by an ophthalmologist. So hepatic copper accumulation is the hallmark of Wilson's disease. So if you are able to get a liver biopsy, if you can quantify the hepatic copper content, and if it is more than 250 per gram of dry weight, then it's the best biochemical evidence for Wilson's disease. So once the diagnosis of Wilson's disease is made, you might need to initiate the treatment, especially if they have symptoms. And your goal is to chelate the copper from your body. So with that, the regular dietary intake in normal individuals is 2 to 5 milligrams per day. But in these patients, you want to restrict the intake to less than 1 milligram per day. And so in symptomatic patients, you might need to start the chelating agent. And the best chelating agent for Wilson's is D-penicillamine. But D-penicillamine is an anti-metabolite, which can cause vitamin B6 depletion. So additional supplementation might be necessary with D-penicillamine therapy. And D-penicillamine is also associated with multiple side effects, and it might not be well tolerated in many patients. Those are the patients you might want to consider other medication called Trientine. And zinc has been also used as a primary or adjuvant therapy, especially in pre-symptomatic patients. And what zinc does is it acts as a competitive antagonist with copper in your intestines and prevent the absorption of copper. That's how it typically helps with the increased copper clearance from the body. And liver transplantation is considered for any patients who presented with acute liver failure or decompensated cirrhosis due to Wilson's disease. Okay, so we are done with those topics. Then let's move on to viral hepatitis. So again, in the United States, viral hepatitis is most commonly caused by hepatitis A, hepatitis B, and Hep C viruses. We have Hep D and Hep E, but they are like the cases with Hep D and Hep E are rare. In addition to viral hepatitis, in addition to our hepatitis viruses, we also have other causes, including adenovirus, CMV, and herpes virus in neonates. So let's move on to hepatitis A. Hepatitis A is a non-enveloped RNA virus. Typical incubation period is 4 weeks, and transmission is by fecal oral route. And clinical manifestations can be very variable. You can have patients who are completely asymptomatic and anictoric, and sometimes you have patients with significant symptoms, including severe anorexia, nausea, vomiting, lots of transaminitis. And the good thing with hepatitis A is there is no chronic state, and most of the time, once they are cleared of HIV infection, they are good. So treatment is supportive care, and prevention is with hand hygiene. So we have active immunizations available, as we all know, all our babies get hepatitis A vaccine at age 1 with a second dose 6 months later. And the other indications are mainly for unimmunized kids who are going to endemic areas for travel, and it needs to be given 1 month before the travel. And any patient with chronic liver disease, you might want to make sure they are immunized for hepatitis A and hepatitis B, because any liver disease patient, if you have a coexisting hepatitis virus infections, they can lead to rapid progression of liver disease. And passive immunization is also available for household contacts or contacts at daycare centers, but it needs to be given within 2 weeks as a single dose. So let's move on to hepatitis B virus. Hepatitis B virus is a DNA virus. Again, mode of transmission can be parenteral, sexual, or perinatal exposure. And there are total 8 HBV genotypes. In North America, we have genotypes A and D, commonly associated with hepatitis B virus infections. Genotype B is the most commonly associated with childhood onset hepatocellular cancer. So incubation period is typically 40 to 160 days, and average is 3 months. Typically, they present with a prodrome of fever, malaise, and nausea, which can progress to jaundice and hepatosplenomegaly, pruritus, and intense fatigue within a 1 to 2 month time. And acute liver failure is from hepatitis B is rare, but can occur up to 0.5% of cases. And chronic HBV, again, can range from asymptomatic to symptomatic hepatitis. It can occur in like clinical phases based on which you decide whether they need treatment or not. And the perinatal acquired infection is common in babies, but typically this type of infection depends on maternal status of E antigen. If mom's E antigen is positive, which indicates a active replicating virus in mom, and it increases the risk of transmission to 90%. Whereas in a E antigen negative mom, the risk is only 20%. Again, we have like multiple antigens and antibodies, serological tests for hepatitis B. But in order to differentiate between acute HBV and chronic HBV, so you are looking at suppose if you take an acute or early phase of acute hepatitis B viral infection, any hepatitis B infection, you need a positive hepatitis B surface antigen. If it is lasting for more than 6 months, then you would call it as chronic hepatitis B. So in a acute active phase, you would have E antigen, and you would have core IgM antibody positive. So these are the 3 typical serological markers in acute early phase. Whereas in the recovery phase of acute HBV infection, your IgM would be converted into IgG, and your surface antigen disappears, and your surface antibody appears, your E antigen disappears, and E antibody appears, and typically your HBV DNA would be negative. And in a replicative phase of chronic hepatitis B virus, again, you need HBsAg positivity for more than 6 months. Your E antigen, as we are talking about replicative phase, E antigen would be positive. Again, we are talking about chronicity, so IgM would be negative, but IgG would be positive. And if you are in replicating phase, your hepatitis B DNA would be positive. So this is more for like refractory treatment mutant strengths. You don't need to know about that. So coming to the treatment, for acute hepatitis B infection, typically supportive care is not needed. Antiviral treatment is like not really necessary. In chronic hepatitis B virus as well, you would only consider treatment if you have persistently elevated transaminases for more than 6 months, and if your liver biopsy shows significant fibrosis. And we have like multiple therapeutic options. Typically, pegylated interferon alpha is used with other antivirals like lamivudine, edifovir, tenofovir. And immunoprophylaxis is very important in babies born to hepatitis B surface antigen mothers. So prevention of perinatal transmission, both by active and passive immunization, is very effective. And infants born to any Hep B surface antigen positive mom, they should receive both HPV vaccine and hepatitis B immunoglobulin within 12 hours of birth. So, and coming to HPV vaccine, as you know, like all our babies, they would get three-dose administration for all infants and children under 11 years of age, and and any other high-risk groups, they also need to get the HPV vaccine. And routine post-vaccination HPV serological testing after the third dose of vaccine is advised for infants born to hepatitis B surface antigen positive women, because if they are not mount actual titers, you might need to repeat the course in them. And typically done in between 9 to 18 months. Before that, the maternal antibodies can interfere, and the antibody from vaccine could also interfere. So let's move on to hepatitis C virus. It's a single-stranded RNA virus, and there are total 6 genotypes which are responsible for hepatitis C viral infections. And you need to get the genotyping to decide about actual treatment response and prognosis. Genotype 1 is the most common in North America and associated with less favorable response to treatment. So HCV is the most common cause of liver transplantation in adults in the US. Mode of transmission is, again, you have percutaneous and non-percutaneous. Percutaneous transmission is with IV drug abuse and also skin tattooing, accidental needle stick injuries. Non-percutaneous, we have risk of vertical transmission. Again, if you have a HIV co-infection in mothers, it significantly increases the vertical transmission of hepatitis C virus. Acute HCV infection is like rare, and most of the times it's asymptomatic. And most of the babies with a vertical transmission, they develop chronic hepatitis. Like an acute liver failure is rare, but you have a coexisting Hep B infection, you can develop acute liver failure, or you can develop rapid progression of liver disease. In chronic HCV infection, again, you can have like a spectrum of symptoms ranging from minimal clinical symptoms to jaundice, transaminitis, and fatigue. And most of the times, if you have a neonate who acquired infection from vertical transmission, like up to 25% of them clear the virus from their body eventually, even without treatment. So the initial testing is anti-HCV antibody, which needs to be confirmed with RT-PCR, with HCV RNA testing. Again, infants born to HCV infected mothers, because of passage of antibodies from mom to kid, you can't consider actual antibody testing until 18 months of age or older. But if you want an earlier diagnosis for any reason, you might have to consider HCV RNA, which can be considered at 1 to 2 months of age. And HCV genotyping should be performed prior to treatment because it determines the prognosis and duration of therapy. And again, liver biopsy is typically not indicated unless you are considering the treatment. And it can tell you what is the staging of the disease, and it would also tells you if the patient is responding to treatment or not. So, and cirrhotic patients, they need to be screened for hepatocellular carcinoma every 6 months with help of alpha-fetoprotein and also liver ultrasound. And here we have treatment options. Again, treatment is not really needed unless you are dealing with genotype 1. And if your liver biopsy already showed more than portal fibrosis or more significant fibrosis throughout the liver, until then you don't really need the treatment. So we have treatments in the form of PEG interferon monotherapy, which can be used for acute HCV infection. And chronic HCV infection typically needs a combination therapy with PEG interferon and ribavirin. And let's move on to hepatitis B virus. As we know, this is a defective RNA virus which does not have a capsule. So it needs hepatitis B to help infecting the patients. So it can cause a co-infection, which means hepatitis B and D simultaneously infect the host. Or you can have a superinfection, which is a patient who already has a diagnosis of hepatitis B, and D can cause superinfection. So again, based on what type of like infection you are dealing with, whether acute and chronic, you need to see a positive HPV antigen, but you see whether IgM core antigen, IgM core antibody, or IgG core antibody. So, and also if you have a HPV, the rate of progression is almost double. And again, for hepatitis D virus itself, you don't really need to have any specific treatment, but you need to treat your Hep B infection, and rarely interferon alpha may be used in these patients. Which brings us to the last viral infection, which is hepatitis E virus, which is an infrequent viral infection, which commonly happens in adults and adults. And the transmission is similar to hepatitis A virus, which is transmitted by fecal oral route. And the clinical course is, again, it's an acute self-limited infection with clinical features similar to hepatitis A virus. And again, there is like no chronic liver disease, but if you have a pre-existing chronic liver disease, it can have a severe clinical course. And high mortality was observed in pregnant women, particularly in the third trimester. And again, there is no chronic state for this viral infection. So these are the references, and that's the end of our liver disorder presentation today. And as part of liver disorders, metabolic diseases will be covered as a separate topic in other GA presentations. Sorry, I did not look at the time. So it's exactly 9, so we are right on time. Any questions?
Thank you so much.
No problem. Have a great day, guys.